Have you ever thought about a treatment that helps your mind, but at the same time kind of harms your body? Well, that's the tightrope doctors walk every single day with certain psychiatric medications. Today, we're diving into a really fascinating case where the cure for one problem created a whole new one, forcing a brilliant, delicate solution. So here's the plan. We'll kick things off with a patient's story, then get into the science of a chemical called dopamine. From there, we'll see the catch-22 this whole situation creates for doctors, look at the strategies they use to walk that tightrope, and finally, see how they found that delicate balance for our patient. All right, let's get right into the real-world story at the heart of this whole puzzle. We're calling it a patient's paradox, where the line between mental and physical health gets incredibly blurry. Because it's so important to remember that behind every one of these complex medical cases, there's a person. And to really understand what's at stake here, we have to start with her story. Okay, so our story begins with a 48-year-old woman. She's been living with a diagnosis of schizophrenia for about 20 years. The reason she's in the hospital now is because she stopped taking her antipsychotic medication and had a relapse of active psychosis. But here's where things get really complicated. When she was admitted, she didn't just have one problem. She had two completely different things going on. On the one hand, psychiatrically, she was in a clear relapse, but on the other hand, physically, she was having some pretty alarming symptoms. Things like galactorrhea, which is a milky nipple discharge, and oligomenorrhea, or irregular periods. This is the central conflict of our story. So just how severe was this physical condition? Well, get this. Her lab results showed a prolactin level of over 6,300. Now, to put that in perspective, the normal range for that hormone is between 55 and about 425. So her level was massively, totally off the charts. To figure out how her psychiatric treatment could possibly be causing this, we've got to talk about one single chemical in the brain, dopamine. So let's dig into the science a bit. Because at the center of everything, both her schizophrenia and her physical symptoms, is one powerful chemical messenger in the brain, dopamine.
So what exactly is dopamine? Well, simply put, it's a chemical messenger, a neurotransmitter, and it's absolutely crucial for regulating all sorts of things, from our mood to our motivation to our ability to move. But here's the key. It doesn't just flood the brain all at once. It works through very specific, targeted pathways. Okay. First up is the mesolimbic pathway. You can think of this as the brain's reward circuit. Now, in schizophrenia, it's believed this pathway becomes overactive, and that's what leads to the so-called positive symptoms, hallucinations and delusions. This pathway is the #1 target for antipsychotic meds. Then you've got the mesocortical pathway. This one's involved in higher-level thinking and executive function. With schizophrenia, this pathway is often underactive, which can contribute to the negative symptoms like apathy or emotional flatness. So you can see it's already getting pretty complex. Third is the nigrostriatal pathway. This one is all about controlling movement. Now, if dopamine gets blocked here, it can cause some really serious movement side effects that can look a lot like Parkinson's disease. They're often called extrapyramidal symptoms, or EPS. And finally, we get to the pathway that is the absolute key to our patient's story, the tuberoinfundibular pathway. Its main job? To regulate the hormone prolactin. And the way it does that is super important. Think of dopamine in this pathway as a brake pedal. It is constantly pushing down, telling the pituitary gland not to release prolactin. This keeps your prolactin levels nice and low. So now we have all the pieces of the puzzle, right? We've got a patient with psychosis, we have a medication designed to treat it, and we have these 4 very different dopamine pathways. And this is exactly where the antipsychotic catch-22 comes into play. So here's how drugs like risperidone work. They block dopamine receptors. The goal is to calm down that overactive mesolimbic reward pathway and get the psychosis under control. But here's the problem. The drug isn't a smart bomb. It's more like a blanket. It doesn't just hit one pathway. It blocks dopamine receptors in all 4 of them. And this slide really shows you the core conflict. You have the antipsychotic, which decreases dopamine activity to treat the psychosis. And then you have the standard treatment for high prolactin, which is a dopamine agonist, a drug that does the exact opposite. It increases dopamine activity. The 2 treatments are basically in a tug-of-war with each other. And all of this leads directly to a condition called hyperprolactinemia. Remember that 4th pathway, the tuberoinfundibular one, where dopamine acts as a brake pedal?
Well, when the antipsychotic blocks dopamine there, it's like taking your foot completely off the brake. The pituitary gland is no longer being told to hold back, and it just starts pumping out tons of prolactin. And that is what was causing all those physical symptoms our patient was experiencing.
So, if you're the doctor faced with this dilemma, what on earth do you do? Well, you have to walk a clinical tightrope. You've got to keep the psychosis in check without letting the physical side effects spin out of control. And luckily, they have a few strategies up their sleeve.
They basically have 3 main plays in their playbook. Option 1, just reduce the dose and hope you find a sweet spot. Option 2, switch to a totally different antipsychotic, like aripiprazole, which is known to be less likely to cause this particular side effect. Or option 3, and this is the riskiest one, you fight fire with fire. You cautiously add a very low-dose dopamine agonist. Now, this could lower the prolactin, but since it increases dopamine, you're running the risk of making the psychosis worse. You have to watch that patient like a hawk.
So, how did this all play out for the patient we've been following? Let's take a look at which path her doctors chose and how they managed to find that really delicate balance.
You know, her treatment journey really required some careful planning. First things first, they had to prioritize her active psychosis, so they started her on risperidone and decided to wait on treating the high prolactin. After 4 weeks, her schizophrenia was stable enough for her to be discharged. Then, 2 months later, they went with option 3. They cautiously introduced a teeny tiny dose of cabergoline, which is a dopamine agonist, and the result? It was pretty incredible. 6 weeks after that, her prolactin levels had plummeted from over 6,000 all the way down to 610, and her physical symptoms started to get better, all while her psychiatric condition stayed perfectly stable. What a success!
And this case really drives home the main message from the research. There's no one-size-fits-all rulebook here. As the author of the source material writes, it requires proper judgment, and you have to take into account the unique clinical situation of each and every patient. It's all about weighing the risks, prioritizing what's most urgent, and really careful monitoring.
And this whole thing leaves us with a huge, critical question for the future, right? This entire dilemma exists because our current tools are, well, still kind of blunt instruments. They affect the whole brain, not just the one single pathway we're trying to hit. So as our knowledge of the brain's incredible wiring gets deeper and deeper, the next great challenge is to create smarter, more precise medications, ones that can fix one pathway without breaking another.